Dinesh TalwarD to give this presentation on which anti-VEGFs should be given and when in diabetic macular edema. We just had a session on macular edema in Hall B just now, but Sir will have a more comprehensive presentation here. Sir was my teacher at RP Center AIMS, and he is now vitreoretinal consultant at Center for Sight in Delhi. And over to you, sir.
For managing DME today, anti-VEGFs are the drug of choice. And this is my disclaimer before I start, financial disclosure. But before you go to treatment with anti-VEGF agents, you must know that in DME, you have patients who have macular leaks starting more than 750 microns or so from the foveal center, and those which are within. Those which are far away from the foveal center, the leaks are far away from the foveal center. Keep in mind that laser is an effective treatment for these patients, and it can decrease the number of injections. Now, not only is laser important, the first thing is this is a multi-pronged attack, and medical management is extremely important. And that includes lipid profile monitoring, HbA1c, hypertension, nephropathy. All these must be controlled too. But from a therapeutic point of view, on fluorescein angiography, check whether the leaks are more than 750 micron from the foveal center, which is half this diameter, or whether they are within that area. If they are within that area, you can't use laser. If they are further away, then lasers can easily be used in these patients. Now, as to which drug to use when, the most important study we have is the protocol T. And what it showed was, well, there is no doubt that aflibercept is the best drug for managing patients with DME. And as compared to all the other drugs, that is bevacizumab and ranibizumab, the difference between aflibercept and ranibizumab does become lesser in the second year, but still persists. Similarly, the macular thickness is reduced to a maximum extent with aflibercept and less with the other two drugs, and the difference does become less over a period of time, but still the difference persists. What is more important is that the improvement is different in patients with different level of vision. So if patients have very good vision, then all the three drugs, that is bevacizumab, ranibizumab and aflibercept, are more or less equal in terms of visual outcome. But if if the vision is less than 612, then aflibercept is definitely better than the other two drugs. Now, the other important thing is that with aflibercept, you can have almost 50% of patients who improve by more than 10 letters at 3 months, that is after the first 3 injections. So you have these as almost like elite responders. 25% of patients are there who actually have less than 5-letter gain. So those are the patients who don't do well. So you know that 50% of patients are going to do very well, 25% mediocre, 25% not do well. But if you persist with treatment, if you continue to give injections, over a period of time, more and more patients start responding, and by that time you've given 6 injections. This is with all the 3 drugs, but maximum with aflibercept, you will find that the improvement in visual outcome has occurred. So if aflibercept was better at 1 year, but not too much difference at 2 years, we can persist with anything. But that's not true, because ultimately, what am I interested in? I am interested in getting the best vision possible at the earliest possible time. And so, what I need to see is what we call the area under curve. For how much time does a patient get better vision? And you get it for almost 1 year more with a particular drug, it's definitely worth it. So, if you have a chance of 15-letter improvement and is going to happen within the first 6 months, don't you think that 1 year advantage you're going to get is worth it? I would think so. But was aflibercept superior in terms of central subfield thickness also? Well, let's see that. Now, what you see is that in patients who have good vision, both aflibercept and ranibizumab are equally good in terms of reduction of the macular thickness. But bevacizumab is not. So keep this in mind for those who say, well, everything is equally good. No, bevacizumab is not as good as aflibercept and ranibizumab. But if you have nothing to offer, then bevacizumab is better than giving no treatment. In patients who have less than 6/12 vision, aflibercept definitely stands out in terms of its ability to dry the macula. So this is very important. If you have to choose the best drug for patients with less than 6/12 vision, it's actually aflibercept. But you can subdivide this further. In patients who have a visual acuity, patients who have a visual acuity of less than 6/12 and whose thickness, macular thickness is between 250 to 399 micron, then both aflibercept and ranibizumab are more or less the same. But when the thickness is more than 400 microns, aflibercept stands out as the drug of choice for management of diabetic macular edema. And that's something you must keep in mind. The other important thing, now at the same time you have patients who can't afford the treatment with aflibercept. Well, don't fret. The patients with laser treatment can sometimes respond, and what you will see over here is that if you have patients whom you give laser therapy in addition to anti-VEGF, now that brings down the macular thickness to the same level with all the three drugs. So if a patient can't afford aflibercept, you could give focal macular laser with ranibizumab and you'll get the same effect. But if the patient wants to be managed on monotherapy, then aflibercept is the way to go. The other important thing, we are not only interested in managing a disease process. I want to make that disease go away. Now, can I make that disease go away? So we have so there was a study which analyzed the diabetic retinopathy severity scores in patients with DME and NPDR, and they found that almost 1/3 of the patients with DME and NPDR, you could regress the diabetic retinopathy. So now this is great. This is a new concept altogether. Not only can I treat the diabetic macular edema, I can make the diabetic retinopathy regress. That is more or less the same in patients with NPDR with DME, but in patients with PDR with DME, in these patients, 75% of patients showed a regression with aflibercept. The figure was lower, around 50% with ranibizumab, but that too works. So if you want the best drug for that situation, aflibercept is the way to go. So what is our paradigm for a cost-effective management of DME? First is you initiate with anti-VEGF. Aflibercept is the drug of choice in patients who have a visual acuity of less than 6 or equal to 615 and a central subfield thickness of more than 400 micron. Both aflibercept and ranibizumab are equally effective if the vision is less, but the thickness is less than 399 micron. If there is an inadequate response to the first 3 injections of anti-VEGF, which will be seen in 75%, which will be seen in 50% of patients with aflibercept and 75% of patients with ranibizumab, add a steroid. Follow up monthly. If there's a recurrence, the drug for recurrence is aflibercept. Add laser for focal macular leaks. And remember, this is a finite disease if it is treated seriously and treated well. Ladies and gentlemen, judicious, rigorous use of intravitreal drugs and anti-VEGF and lasers can provide an improved and sustained visual outcome in patients with diabetic macular edema. Thank you very much, Neeta.
Before sir goes for another session elsewhere, so if there are any questions, you could please come up. We'll offer you the mic here. Sir, I'll begin by just asking you a question. So, sir, would you look at the patient profile and not offer aflibercept in certain situations, or
Patient, I have seen you have patients who come in dhoti kurta and they are multimillionaires, and you have a patient who comes in a shirt and a pant and you think, well, this guy is well off, and the fellow starts crying, I don't have money. So I don't make an attempt to decide who can afford it, who can't. I give them the options. And I say very clearly that the important thing is what you can afford over a year, not injections, but if you can afford something over a 1 year period, that is the treatment you should. And I just tell them the average cost for it.
And sir, would there be a difference in the number of injections that you would require with aflibercept versus ranibizumab?
No, not in the first 2 years. What you get is better outcomes. You get better outcomes, but you don't get less injections. The injection difference is very small. There is a small injection, maybe 1 injection or so, but not a huge difference. But the main difference comes in the outcomes. And ultimately, I'm more interested in the outcome. How do you put the value of one line improvement?
Right. And are there any biosimilars to aflibercept?
Yes. So for ranibizumab, we have biosimilars available. And if the patient says he can't afford the innovator, then the biosimilars are available too. Again, I don't decide for the patient biosimilar or innovator. I will tell the patient, this is a drug which has been used across the world in something like a few million cases. This is an Indian version of the same thing. Give them the example of an Indian Crocin versus Tylenol. Say both work. This costs less, has been used in maybe 150,000 cases. Now you decide, you want to say you want the imported one, or you don't want to take this thing, alright? You say you want to take the biosimilar, go ahead. But where I believe that the patient will benefit from aflibercept, I do let them know. For example, with aflibercept, there's a patient support program. Now, obviously, with the patient support program, the cost of the innovator aflibercept and cost of aflibercept and the innovator ranibizumab is the same. So then I give them that choice, but you can then, if you are going to spend so much money, you can go for aflibercept.
Any questions from the audience, from anybody in the audience? Okay, then we'll move on to the next talk. Thank